Hello everyone, welcome to our video on the Lemniscal System as part of the UIMS Neuroanatomy video series. Today we'll be talking about this topic, the dorsal column tract. My name is Adhish. I'm from the fourth year of medicine in the first faculty of Charles University.
And hello everyone, I am Foteini Kousteni, a fifth year dentistry student in the first faculty of medicine in Charles University. This video is really important, not just for your exams, but also for your career as a doctor. So these are the sources that we used. We will have them also in the description of the video because they're very useful for your own studying. So first of all, we will go through an introduction about the ascending tracts, and in the rest of the video we will focus on one of them, the lemniscal system. We're going to describe its pathway from the peripheral receptors all the way to the brain.
We'll also have an overview of the different sensory modalities that are transmitted by these tracts, and specifically about the proprioceptive and tactile information. We'll also be going through the spinal cord lesions, which, as you know, is quite important when considering the clinical impact of these lesions in this tract.
And that's also why you really need to know about the theory of this system. So, what is an ascending tract? You can pause the video and try to think about it a little bit. So it is a bundle of axons in the CNS ascending. That means they're going up from some parts of the body, like the leg or the arm, running through the spinal cord up to the brainstem, and they end up in specific parts of the brain. They carry what kind of impulses? They carry pain stimuli, thermal stimuli, tactile stimuli, and stimuli from muscles and joint receptors. So some of this information will reach the conscious level, that means you are aware of it, and some of them to the subconscious level. So conscious level, that means cortex, and subconscious level, that means cerebellum. The pathways that reach up to the cortex, they have something in common. They have a sequence of 3 neurons. Those 3 neurons will start from the peripheral receptor, and the third neuron will end up in the cerebral cortex. So what's the lemniscal system? The lemniscal system has also another name. We mentioned it before. So the other name is the dorsal column tract. And where is it located? The location of the dorsal columns is between the dorsal medial sulcus, which you can see here, and the dorsal horn over here. And it's divided into 2 fasciculi. The most middle one, this one, what's the name? The name is gracilis. And the lateral one is called fasciculus cuneatus. What are the impulses that this specific ascending tract is carrying? So, what can you see in this picture? That means that it can carry proprioception. If a blindfolded man knows where the hands and the legs are. Then you can also have the discriminative fine touch. That means that you know if you're touched in 2 different points, you know that there is contact into those 2 different points. Then vibration. This is another impulse. And you can also be aware of pressure on your skin. Great. So what's the pathway through the CNS? What differentiates the lemniscal tract from all the other ascending tracts is the fact that the first order neuron, the neuron that enters the spinal cord, will start ascending up to the medulla in the same side. So does it enter from the right side? It will go up in the right side of the medulla. And it is completely uninterrupted until this point. Then you have the second order neuron. the second order neuron decussates. That means that it will cross to the contralateral side, to the other side. So from the right side, it will go to the left side, and then it will start ascending up to the thalamus. There it will synapse with the third order neuron, and the third order neuron will project up to the ipsilateral cortex. That means the same side exactly. So this is very important. Then let's talk in more detail about the first order neuron path. So if, for example, there is a stimulus starting from the lower limb, this stimulus will travel through the first order neuron. It will enter the spinal cord through the dorsal root of the spinal nerves. And can you see the cell body? Where is it located? It's located in the dorsal root ganglion. What's a ganglion? It's a collection of cell bodies. It's a collection of cell bodies in the peripheral nervous system. So those fibers will continue and they will enter to the dorsal horn, and they will project in the fasciculus gracilis, very important, lower limb fasciculus gracilis, and then they will ascend uninterrupted up to the nucleus gracilis. What's a nucleus? A nucleus is a collection of cell bodies in the central nervous system. And be careful. We have sacral level, lumbar level, and the lower thoracic level. This from when the first order neurons enter the spinal cord from these levels, they will ascend through the fasciculus gracilis. So remember that. And they, of course, stay ipsilaterally. Perfect. And we answered that. Then we have the first order neuron. If it starts from the upper limb, then it will again go through the dorsal root of the spinal nerve to the dorsal horn. They will enter the spinal cord through the upper thoracic and cervical levels, and they will go to which fasciculus? To the fasciculus cuneatus. We will ascend uninterrupted up to the nucleus cuneatus in the medulla. And there, of course, the same ipsilateral, and there they will synapse with the second order neurons. So what can you see here? You can see here that most medially we have the sacral level. When the first order neuron enters through the dorsal horn, they will go to the most medial part. Then if you have a first order neuron from the lumbar level, they will enter the dorsal horn and they will go laterally to the sacral level. This is called the somatotropic arrangement. So sacral, lumbar, then thoracic, and then cervical. Sacral, lumbar, lower thoracic is part of the fasciculus gracilis, and upper thoracic, cervical, part of which fasciculus? Fasciculus cuneatus. Now, second order neuron. The second order neuron, the cell body is in the nucleus gracilis or nucleus cuneatus. It will decussate. It will decussate. That means it will cross to the other side and forming the internal arcuate fibers. And those internal arcuate fibers will make the medial lemniscule, which is in the brainstem. They will ascend in this structure up to the thalamus. And which part of the thalamus? The ventral posterior lateral nucleus, VPLN for short. And there, this is where they end up, and they will finally synapse with the third order neurons. So remember, decussation, medial lemniscus, and ventral posterior lateral nucleus. Now, third order neuron. So, where did we say the third order neuron starts? At the VPLN, that means ventral posterior lateral nucleus of the thalamus. Then it will go as the thalamocortical tract to the posterior limb of the internal capsule. The internal capsule has the posterior limb, anterior limb. So remember, posterior limb. They will form the corona radiata. This is those like fibers that radiate to the cortex. And which part of the cortex? The primary somatosensory cortex, which is located in the postcentral gyrus of the parietal lobe. And this is a very weird human being, I know. It's called the homunculus, and basically this is where each part of the body is seen in the cortex. So if there is a stimulus that you feel in the tongue, the fiber, the third order fiber that carries the stimulus, will end up in this part of the brain. If there is a stimulus from your index finger, the third order neuron will end up somewhere here. So this is the homunculus. And one more thing, the somatosensory cortex is depicted by blue color here, and it is in the parietal lobe, posterior to the central gyrus, post-central gyrus. Thank you very much. That was my part. So now it's Adhish's turn.
All right. Now we're going to be talking about the different sensory modalities that we can experience. They are broadly classified into proprioceptive information, exteroception, and interoception. And as we know, these different sensory information are carried by different tracts. But today we're going to be focusing on the information that is carried by the dorsal column pathway, which are conscious proprioception and tactile sensation. These are the two sensory information that are specifically carried by our dorsal column pathway, and we will be talking about both of these in detail in the next few slides. So what is proprioception and what do we mean by it? So it is basically the awareness of our body parts in relation to oneself in 3D space. This proprioceptive information is sensed by specialized mechanoreceptors that are present in our skeletal muscles, tendons, and fibrous joint capsules. This information in turn is transmitted to the CNS via the posterior column, which we've been talking about, and also additionally via the spinocerebellar tract. It is important to recognize that this proprioceptive information is also integrated with visual and the vestibular systems to create an overall picture of our body position, movement, and acceleration. So we basically have three major proprioceptors that are present in our body. That is the neuromuscular spindles, the Golgi tendon organ, and the joint kinesthetic receptor. So the neuromuscular spindles, which are present in our intrafusal fibers, measure the rate and degree of stretch. The Golgi tendon organ monitor the tension in our tendon, whereas the joint kinesthetic receptors measure the stretch in our synovial joints. Additionally, we also have the Ruffini and Pacinian corpuscles, which are exteroreceptors, which are present on the surface of the skin, but they also help in sensing proprioceptive information by measuring the degree of the pressure and the stretch. So in this picture, you can see an overall representation of the different sensory fibers and the motor neurons that are present that are innervating the muscle. So let's move on to tactile sensation. Tactile sensation, or our sensation of touch, is mediated by special cutaneous mechanoreceptors that are located on the surface of the skin. And since they're on the surface of the skin, they're called exteroceptors, and they measure pressure, touch, and vibratory sensations. And as we know, they are carried by the dorsal column tract. So we basically have four major tactile mechanoreceptors that are present on the surface of the skin. They are the Merkel discs, Ruffini corpuscles, Meissner corpuscles, and Pacinian corpuscles. All of these are present in our hairless skin. There are also special mechanoreceptors that are present in the hairy skin, for example, in the cochlea, which are one of the most sensitive mechanoreceptors that are sensing auditory information. So all of these mechanoreceptors are innervated by A beta fibers, except the free nerve endings, which are innervated by A delta fibers. So these mechanoreceptors can be categorized by their morphology, by the type of sensation that they are receiving, by the rate of adaptation, and also by the receptive field, which means the particular region of the body part that they are present in and are receiving the sensory information. So, for example, in the Merkel discs are present in the superficial skin. The Ruffini corpuscles are present in the subcutaneous tissue, especially in the region of the fingers and toes. The Meissner corpuscles are present in also the superficial layers, whereas the Pacinian corpuscles are present in the subcutaneous tissue. It is also important to recognize the categorization known as the adaptation, which is basically how quick the receptors are able to respond to the sensory stimuli. So they can be categorized into two, that is the slowly adapting and the rapidly adapting, as you can see from the table. And this is important when we are talking about the different kind of touch sensation that we are receiving, that is the static touch versus the dynamic fine touch. So as you can see in this picture, we can clearly distinguish between the static and dynamic touch. The static touch is usually caused due to the stretching of the skin, in which the receptors are firing continuously as long as the stimuli is present. Whereas in the dynamic touch, the receptors are modified so that they fire only during the touch sensation is first present and when it is removed. As we know, we previously talked about discriminative touch. So the proprioceptive information includes the sensation of accurately exactly where in the body we are touched, and also how to sense that if 2 points are being touched at the same time, even if they are close together, we are able to distinguish it. So finally, let's move on to the clinical manifestations of proprioceptive signals. For example, what would happen if there is a lesion in that particular region? So as we know from our anatomy, we've spoken that the dorsal column tract is present in the posterior portion of the spinal cord. So any lesion that affects this region can cause a loss in the information that is carried by this tract. And to refresh your memory again, it is the proprioceptive, conscious proprioceptive information and the tactile sensation. So for example, different lesions such as the posterior cord syndrome, the tabes dorsalis, and vitamin B12 deficiency can cause damage to this particular region, which is the dorsal column tract. Also, an important thing to remember is that these symptoms are seen below the level of the lesion, and this gives us an approximate indication of where the lesion could be. The definitive diagnosis would have to be done by the radiology, such as MRI. So let's first talk about the posterior cord syndrome. So what does it mean? This posterior cord syndrome can be caused by a variety of etiology, and this is basically the injury of the posterior spinal cord, which is affecting the dorsal column and affects the sensation of fine touch, vibration, pressure, and proprioception. An important thing to recognize is that this epidemiologically is a very rare syndrome, but it is still important to consider the various etiology that can cause this syndrome. So the most important ones to recognize would be the trauma, which could be a penetrating injury or compression due to a tumor, for example, and the occlusion of the posterior spinal artery, which is coming from the vertebral arteries or the posterior inferior cerebral artery. Another important etiology is multiple sclerosis, which is an autoimmune demyelinating disease which can affect the dorsal column tract. So what would you see in this syndrome? It is important to remember that there is a bilateral loss of proprioception and other sensory information below the level of the lesion, as I said before. And this leads to a condition called sensory ataxia, which is basically the loss of coordination of voluntary movement. And in this patient, you can probably see poor balance, that he's falling over and he's not walking properly. So from this picture, you can see that the posterior cord syndrome is affecting the posterior, the dorsal column tract bilaterally, and that's why we can see a bilateral loss of the sensation. Another important etiology to consider is the tabes dorsalis. Do any of you remember from your microbiology what this is? So this is a condition caused by the tertiary syphilis, which is a late stage of infection with the Treponema pallidum, which is a spirochete bacteria. And this causes the demyelination of the spinal cord and specifically affecting the posterior column. So what this causes is it causes impaired proprioception and this can be seen in a condition called sensory broad-based ataxia, and this can be recognized by performing a test known as Romberg test. We can also see a loss of sensation, especially in the lower extremities, and dysesthesias, which is a normal sensation that can be like discomfort or itching or some burning sensation. And many patients describe this as similar to being shocked by an electric signal. The most common manifesting symptom is a sharp shooting pain in the legs and the abdominal region. So as you can see in the picture, how to perform the Romberg test is usually a patient will be standing up straight with his eyes closed, and if he is falling over or to one side or the other, it can be considered as a positive result. And from this histological slide, you can see that demyelination in the posterior region is causing this syndrome. So another tertiary etiology to consider is vitamin B deficiency, because in late stages, this can affect the posterior spinal cord, leading to peripheral neuropathy or paresthesias, and can also interrupt proprioception. So that's it from us. I hope you could take up a lot of information from this slide, and hopefully it'll be helpful for you in your future exams.
Thank you very much, guys, I hope it really helped you. I hope you paid attention, and good luck with everything. So, yep, that was a lot for sure. There's a lot to know about the human body, and keep in mind this is just one tract. So there are more things you need to know about the nervous system and how it keeps us alive. I hope you will find this series useful for your exams and your career, and see you next time.